My name is Paula McFadden. Thank you very much for the opportunity to present today some of the findings from our research so far on wellbeing, work and life and coping strategies while working during the COVID-19 pandemic. So we began this research in May, so over a year ago now, and we ran our first survey between May and July 2020. We ran the second survey between November and the end of January into 21. So we're going to be able to talk to you about the comparisons between those two time points. Our third survey is currently open, and we're going to give that a mention today because it doesn't close until the 2nd of July, and we really would welcome people to participate and highlight this research study. I'm going to hand over to my colleague Jermaine, Professor Ravalier from Bath Spa, who's going to just take you through the first few slides. Thank you.
Good afternoon, everybody. I'm not going to spend too much time on some of these slides because I appreciate that, you know, talking through kind of stats and stuff can be a little bit dry, but what I will do is provide some context. So as Paula has said, the aim of this project was to examine the impacts that COVID has or has had on health and social care professionals across the pandemic. So the focus was particularly on frontline staff, so nurses, midwives, AHPs, social care workers and social workers. It is an anonymous online questionnaire, as well as a bunch of focus groups that were conducted late last year, early this year, I can't remember. But we've collected two sets of data so far. So the first was between May and July, and the second was between November and January. And you can access both of the reports outlining the findings of those two studies, or those two runs of the survey on our website that you'll find later. So the questions that we've asked people to complete, and again, I won't go into these in too much depth, but the questions that we've asked people to complete were around the demographics. So that's just kind of explaining who they are. So standard things, age, gender, ethnicity, whether they have a disability, etc. The second one was about mental well-being. So the aim was to look at the impact of COVID on the mental well-being and working conditions of these key frontline professions. So we use this thing called the short Warwick-Edinburgh mental wellbeing scale, which we use because it has UK-wide benchmarks. So we can compare how our sample at both phases 1 and phase 2 have fared versus the UK benchmarks. We then looked at work-related quality of life, which is made up of a number of things, but it's kind of what your quality of life is like at work. And we looked at career satisfaction, stress, well-being, homework interface, control or autonomy, and working conditions. The fourth measure we used was on burnout. There's been a lot of talk about burnout with respect to healthcare over the last week or so, and we're going to reflect on that in a little while, as well as questions on coping, and some open-ended questions that Denise is going to go through shortly. So for fear of sounding like I'm on a parliamentary, thank you, Denise. Demographics. So again, I'm not going to go through this in any real depth, but these are the questions that we asked in order to kind of explain who our population is. And you can see that in phase 1, most of our respondents, over half, came from Northern Ireland, whereas in phase 2, we had a much broader range from across the UK. But over those time points, the demographics were relatively similar. So mostly female, over 3,000 participants or respondents at each time point, mostly aged between 30 and 59, etc., etc. And the interesting thing is that when we compared our findings to the statistics that were available nationally for health and social care professionals, we found that our sample was very representative of the UK-wide health and social care sector. So next slide, please. So this is the number of respondents we had per occupational group in survey 2. and you'll see that mostly was social work and social care. And I think that's particularly important because while we hear a lot about doctors and nurses, and again, the recent parliamentary committee report looked at the NHS, social work and social care is often overlooked. So it's really interesting that we've got a lot of responses in phase 2 to social work and from social work and social care workers. Thanks, Denise.
Okay, thanks very much, Jermaine. So I'm just going to take you through some of the qualitative responses. We asked a number of qualitative questions in the 2 surveys, and really we wanted to understand in a little bit more depth the experiences of the health and social care workforce in their own words as such. So we identified when we analysed this data 3 major themes. These themes came across in phase 1 as well as phase 2. So they were very similar, but there was certain trends that differed. Changing conditions, connections and communication. So the questions we really asked were about the impact of COVID-19 on their specific place of work and the demands on services and so on. We asked them to describe employer supports, how they have worked through COVID-19, what could be improved. And we also gave the opportunity just to tell us anything else that they wanted to share with us. So I'll give you a snapshot. There was a lot of data to go through and some really interesting responses, but I'm going to give you a little snapshot of really what we discovered. So firstly, in terms of changing conditions. So in phase 2, services continue to be widely disrupted, obviously, and there was concerning implications for the health and social care workforce. But I suppose responses revealed additional pressures in phase 2 that weren't so overt in the responses from phase 1. So respondents said that they were continuing often to meet the demands for COVID-related care, but many also were re-engaging activities that were either halted or curtailed in phase 1. Respondents, as a result, expressed a lot of concern about the needs of service users and their patients, and whether they were being met throughout the pandemic, both for COVID and for non-COVID services. So factors like delayed diagnosis, delayed admissions, lack of respite for families, demands for mental health services, staff shortages, longer waiting lists were all factors in these responses. And as a result, respondents obviously faced increasing demands for services and therefore inevitably work intensification and increased stress. So this work intensification, often manifested as well in staff having to work overtime, longer hours just to cope with the demands, as we see from this quote. Sometimes having to work 50 to 70 hours, as one social care worker described. Our social worker, and that's unsustainable. And in our analysis, we also found that respondents reported working more hours of overtime since the pandemic started, just generally, and also found it more difficult to take annual leave. Other comments made around this area was really around frustrations that, yes, their workload increased, yes, they were given offers of support, but at the same time, this was accompanied with more requests for doing more. So they were quite frustrated about that, as well as, having to do activities that they thought were unnecessary at the time. Another key theme, obviously, is working from home for some members of this workforce. Particularly social workers, and managers. So the mandate or option to work from home was overwhelmingly received positively by many of our respondents, and explained many of the benefits. However, there was a number of points made about the importance of, for example, ensuring that you've got access to managerial support, having structured meetings, taking breaks. The need to discuss flexibility around hours and concerns were also raised about how working from home in the long term may have concerning implications for work-life balance and general health. And as this quote had said, you know, it does have its advantages, but, you know, is it really healthy in the long term? In terms then, I suppose, related to that, in terms of working safely, and the last point around being recognised for all your efforts, this kind of sums it up. But so most respondents, in terms of working safely, felt satisfied with how employers were adapting working conditions and practices to ensure a safe working environment. But I suppose what also came out, especially for social care workers and those in the community, was that they still felt very fearful of the risk of COVID. And this was further compounded by this feeling of being undervalued, so risking their lives and yet then being taken for granted. So this feeling of being unrecognised, I suppose, was particularly apparent as well for those who were redeployed in our survey. And they felt sometimes unsupported, unprepared for their new roles. But, you know, it wasn't all negative. There, of course, were lots of reports to say that employers were doing what they could to recognise the work of their employees, and it was these small initiatives and so on that were welcomed by as well. So going on to the next theme around connections. So the theme of connection emerged as a really strong feature across the responses from all occupations and all countries. And really this is about understanding the relationships and the importance workers placed on sustaining relationships and connections with people they work with. And that might be with the service users, with team members, or with managers. So in terms of the service users, it was a real concern, I suppose, about service users and their experience of care. And it was very much centred on the emotional and psychological well-being of their service users, more so maybe than the physical needs. Respondents reported feelings of helplessness in trying to support service recipients, and themes around, you know, the social distancing restrictions, online case conferences, for example, not being able to give that personal touch really when working with the people they're supposed to work with. And there was, therefore, that led to concerns around disengagement from their service users. So that was quite a concern that was raised in the responses. But then, on the other hand, you know, depending on the demands of the service and what was happening, there was some positive experiences noted that actually some had more time to really devote to their service users and listen more and work at a slower pace. In terms of connection with teams and team members and colleagues, well, respondents overwhelmingly agreed that having mechanisms to sustain supportive relationships with colleagues and team members was really important for helping each other cope and to address the concerns, the fears, the isolation associated with working on the front line of the pandemic. So many respondents noted the importance of working as a team, but sharing ideas, sharing information, really just supporting each other through what they described as the roller coaster. So it was that closeness that really developed within teams, which seemed really instrumental for building and supporting their resilience. Now, we noted that there was lots of mechanisms to do that, and very much as well in phase one, that lots of, you know, informal meetings and check-ins and so on across team members were used. But then we noted that some people were saying that those efforts had kind of dissipated as the pandemic wore on. In terms of the relationship with managers and supervisors, so obviously managers are just instrumental in creating the conditions for how connected workers felt and how relationships could be maintained, particularly when working from home, where many felt isolated. We have to say that I suppose experiences of manager support was pretty variable across the piece, with, you know, some really appreciating the regular check-ins, both formal and informal, whereas others reported on their frustrations around being left to their own devices, being disconnected and not listened to. But it's also important to note that it was recognised that a manager's job to stay connected with their staff was particularly difficult, with managers suggesting that they just felt exhausted with all the efforts to keep in touch. So they were kind of stuck in the middle a little bit. But and just to note here is that we specifically found that line managers scored higher than those that were not line managers in terms of well-being, but still lower than the overall population. So, you know, quotes like "I've never felt this deflated, not listened to, disposable, or not in control for 27 years" really hit it home in terms of the, you know, the feeling that some respondents had in terms of their support from managers. But, you know, on the other hand, there was lots and lots of comments saying that managers were going well above and caring for and feeling cared for. So lastly then, in terms of communication, again, another critical area that respondents commented widely on. I suppose when we compared the two phases, we noted that there was less concern about poor communication in phase 2 compared to what was reported in phase 1, which was welcome. But, you know, having clear guidance and information continued to be cited to be very important. You know, being involved in decision making and processes and being listened to instead of just being passive recipients of information was also very important too. So given the understanding though about how the virus was evolving, there continued to be changes to the guidance obviously given to managers and frontline staff. And although this was expected, these daily changes were reported to be overwhelming by some. On the other hand, other respondents bemoaned that they didn't have enough relevant information for them to do their jobs well. And this was compounded by conflicting guidance from managers or from local authorities or from government, or how it was translated to the front line. So there was a wee bit of "we have to work it out ourselves" a bit, reported from some. In terms of decision making, respondents really noted the importance of being kept informed on a regular basis, but it was two-way communication was deemed integral for their well-being, and that information as well for protecting their own families about, you know, the prevalence of the virus and so on. So on the other hand, though, despite regular meetings with management, some felt that they were not being listened to, that their concerns were being ignored. On the other side of the coin, frustration arose from managers that when, you know, despite listening to and trying to understand these concerns from employees, that they were at times powerless really to do anything and to address the issues. And lastly then, in terms of supportive communication, the perceptions of management support and communication varied across occupations. Some saying they really just flatly did not feel supported, where others saying that managers really could not have done enough. I think the key thing here is that a strong theme from the responses was that although there was maybe greater appreciation of local and team managers who communicated well, there was a little bit of more frustration around corporate pronouncements about these issues. Some workers feeling satisfied with their own line manager's support and communication, but dissatisfied really with the visibility or the support and communication from senior management. So that was a key finding as well. We also did lots of focus groups, and it was really a couple of focus groups, and it was really interesting to hear all the individual stories relating to the individual circumstances of those individuals, and it just they are highlighted in the report as well. So it's worth having a read of them just to get a clear picture of really what one single person could have been going through at this point in time. I'm going to carry on, like Jermaine can carry on with all the quantitative stuff around the measures that we had in the survey.
Thank you, Denise. I think those qualitative findings really put things into perspective really nicely. So I'm going to look at our quantitative findings, so of those surveys that I outlined a little while ago. And I'm going to start with this thing about mental well-being. So that was the Warwick-Edinburgh scale that we used. And if you just have a quick look at the graph, you'll see the differences in our different occupations, nurses, midwives, etc., at phase 1 and phase 2. So the grey box is phase 1, which was the earlier part of the pandemic. And you'll see that those graphs, those lines look only very slightly different. So phase 2 looks only slightly lower, and you need to kind of indicate that higher scores, so the higher graph indicates better psychological well-being. And while those differences appear small in the graph, actually what they demonstrate is that for each profession, mental well-being was significantly worse at time 2 than it was at time 1. So it appears that working through the pandemic within such a vital workforce has had an impact on the mental and psychological well-being of our frontline health and social care staff. Next slide, please. And then you have a look at work-related quality of life. And while we looked at kind of those 5 or 6 smaller factors, they kind of add up to one overarching outcome, which is work-related quality of life. And it's similar here. So while the differences in each occupation are relatively small, according to that graph, the differences are actually significant. So there is a significant worsening in work-related quality of life between the 2 phases that we in which we collected data. So it appears that both psychological well-being, but also the quality of working life of our frontline staff reduced significantly over that 8 or 9 month period. And next slide, please. And this one, so this is a bit of a busy slide, but actually this is, I think, the one which puts everything into perspective really nicely. So you'll see that the different colors on each of those 3 things represent a different occupation. So purple is nurses, yellow is midwives, etc. And this burnout measure, so when we think about burnout, we think about, you know, when you kind of hit a wall and you can't do any more, work has kind of almost broken you at this point if you're burnt out. It's made up of 3 specific areas. It's made up of personal burnout, which is kind of a prolonged physical and psychological exhaustion. As I said, when you get to that point where you're just exhausted at the end of a hard, however long it's lasted. The second is work-related burnout, which is exhaustion as it relates to your work. And the third is client-related burnout. So that exhaustion is due to working with clients, or in our case, service users and patients. Now, I say interesting, I guess it's interesting, surprising, a little bit difficult to consider, is on the right-hand side, you'll see some numbers in brackets. So under personal burnout, you'll see the number 36 on the right-hand side. And under work-related burnout, you'll see 33. They are the national average scores on personal burnout, work-related burnout, and client-related burnout across the UK. Now, if you have a look at our average scores, our mean scores per area of burnout and per occupation, you'll see that both personal burnout and work-related burnout are each almost twice the national average in levels. So burnout is almost twice, in those 2 areas of burnout are almost twice as bad as they are in phase 2 as they are compared to the national average. So it kind of suggests that those 2 areas of work are really negatively affecting our frontline staff. But the one thing that does stand out is that client-related burnout, or patient or service user-related burnout, is actually slightly lower or about the same as our national average. So it's between, you know, in our sample, it's between 28 and 31, and the national average is 31. So what these findings suggest is that while people working in health and social care, they are still engaged in their work, and it's the working with patients and service users, which is the reason why 99% of our health and social care workers go into the job. It's working with those people which is keeping them from becoming clinically burnt out, whereas it's all of the other stuff around being a nurse or a AHP or a midwife or a social care worker or a social worker. It's all of that other occupational stuff, that work-based stuff, that is contributing so significantly to poorer levels of burnout in our sample. So that's really interesting. It's not the patient-related stuff, because people go into those professions in order to make a difference. It's all of the other stuff around working as a frontline health and social care worker in this country across the pandemic, which is causing the problem. Thank you, Denise.
Okay,
Over to Paula.
Yeah, thank you, Jermaine, and thank you, Denise, for the lead into this. So this slide is another busy slide, but what we're trying to demonstrate with this is, again, the ways of coping at the two survey time points. So phase one, you'll remember, was whenever we were all just adapting to being aware of the pandemic hitting. And you can see with the grey bar the higher scores at the first phase, and then reducing when we get towards the second phase. So basically what we did, we measured ways of coping using two different scales, a combination of them, to look at a range of different ways of coping. And what we have found is that positive coping, such as active coping, planning, and positive reframing and acceptance, they were all used more frequently than negative coping, such as substance use, behavioural disengagement, venting, and so on. So more positive coping at the first data phase, and by the time we got to that period over Christmas from, you know, November through to the end of January, what we found was the positive coping averages had fallen, and instead the negative coping had increased. So, you know, this really tells us that over time there is a process of deterioration as people get more exhausted and more burnt out, that they start to adapt by using negative coping. So if we just move on to the next slide, Denise. We did multiple regression analysis just to explore this further, you know, in a range of different ways. So what we found that was confirmed by this analysis was that positive coping, such as active coping, positive reframing, acceptance, and exercise, were all associated with higher mental well-being scores, better quality of working life scores, and lower burnout scores. On the other hand, negative coping strategies such as venting, substance use, and self-blame were associated with lower mental well-being, worse quality of work and life, and higher burnout scores. So you can see, you know, the pattern that is emerging, you know, whenever you are using either positive or negative coping, and then what the associated outcomes have the potential of being. Can we move to the next slide, Denise? So emerging from the qualitative data from the first survey, we categorized three groups of people that were providing comments. There were those that were overwhelmed by the pandemic, hit directly by the work they had to do. There were people not affected. They weren't expressing any change to the service that they were delivering. And there were those that were interfacing with the people that were directly affected. And so we were able to then, at the second survey point, ask people to self-identify with which group they felt they belonged to. And as you can see here, like UK-wide, you've got only 4.60% of people that weren't impacted. And then you can see it's equally small across all of the countries. Really, the majority of people were overwhelmed by increased pressures or impacted, but not directly. So you can see there weren't very many that really went unscathed in the current pandemic cycle that we're in. So if we could move to the next slide. So this slide now brings us to good practice recommendations, again, that has emerged from the findings, and in particular the qualitative findings. So I know Denise is going to speak to the first 4 of these. If you want to go ahead, Denise, thank you.
Yeah, I mean, these are just a very short summary of all the various recommendations we made in the report, and relating to some themes that came out, particularly in the qualitative analysis. Our recommendations are structured around, workplace organisational and policy recommendations, but just generally, and I think this is really where we want to set off our discussion with those who are with us today. We want to understand a little bit more about, how these recommendations apply in your organisations, how the challenges that maybe you've had in addressing these themes around the recommendations and so on, or what have you done well. So coming from the data, we're recommending to employers to offer more flexibility, potentially around working hours and location, especially when working from home. Now this is obviously in the context of the pandemic or any other kind of future crisis or where there's real, specific need. But that understanding, when there's so much going on during the pandemic, all those individual circumstances, there needs to be some kind of flexibility in response to that. And as I said, those stories really came through in the focus groups. Clear and relevant communication. I mean, that theme obviously is doesn't need to be argued for. And I think what really is important there, even when there's not information to communicate, even when there is still uncertainty about certain issues, is that communication about that uncertainty and labelling it, that's still obviously important. And certainly a lot of our managers in the focus group reiterated that the importance of communicating even when there's no information or no new information to communicate. Staff, very keen to become more involved in decision making, needing more autonomy around these issues, and that was potentially different across the different occupations. Social work, for example, Paula could maybe talk to in a little bit more detail, but certainly when there's decisions, it's about that consultation with staff on the front line, ensuring that that their experiences of really what's appropriate on the front line is taken into account, and establishing the processes and procedures to enable that consultation, so that frontline workers feel as if they do have a voice. And I suppose it's very hard to balance when decisions need to be made quickly, but it's obviously something to be mindful of. Training, certainly in relation to redeployment, and that was a key feature for many of our respondents in the survey. Many feeling that when they were redeployed that they maybe didn't have the skills, but that's an important feature, I suppose, moving forward, is that should, God forbid, this situation ever happen again, is your workforce flexible? Will they feel prepared to jump in when needed? How are individuals able to perform these multiple and new roles? And what processes are in place to enable to get that training and ensuring that they are prepared in an efficient manner. Paul, you want to take over?
Yes, thanks, Denise. So the remainder of these, statutory sick pay should be addressed throughout the sector. So we were picking that up more from people that were working in private sectors, that they were sometimes not even getting statutory sick pay. And at the earliest stages of the pandemic, people felt that they were taking risks. They were going to work and they weren't sure if they had symptoms of COVID, because they had a fear of not getting paid. So statutory sick pay as a basic would need to be in place, you know, for the workforce. So that's something at policy level. From an organisational perspective, employers should support taking breaks and holidays for recovery. There were people that were forgoing their annual leave or asked to forgo it because they had to cover for absent or shielding colleagues, and they, you know, really feel exhausted. By the time we went to the second survey point, they were feeling like they had nothing left to give. So they're really going to have to be encouraged to take their annual leave, ensure that they get frequent breaks. And that includes managers. Managers had a very difficult job at managing through this situation and supporting the frontline staff. And as Denise has already said, sometimes they did that well and sometimes it was done poorly. Connection with colleagues and managers. So that connection, even if it was virtual, really made a difference to people's well-being. And that was borne out in their scores in terms of their overall well-being scores. So it does have an impact at social connection. So just encouraging visibility of management, which is the next point, and connection with peers and colleagues. And a focus now on staff well-being and recovery. You know, employers are, I know there's been lots of work going on in terms of well-being hubs, manager toolkits, lots of really innovative work has been going on, but there's probably a lot to be done and to do. And we are interested, and Denise is going to just pose some questions now about how you think we take those steps, the next steps. Producing this evidence is one thing. It's about how do we make it the evidence base from which you can then plan your next steps as employers. So I'll hand you over to Denise. Thank you, Denise.
Oh, sorry. So I suppose just before we get on to the discussion, Paul, maybe you want to just acknowledge.
Yes, you're right. Yeah, we can do that first. So just to acknowledge all the participants in the middle of everything that they were going through. They took the time, 15 or 20 minutes to complete the survey. And without them doing so, we would not have this evidence base. So a deep appreciation to participants first and foremost. We are calling on you again, please complete phase 3 survey that is now opened. My email address is on the next slide, but I'm contactable through Ulster University website. And we can, you know, link you up if you're having difficulty finding the survey link. It's on Twitter, pinned to my profile as well. So we would really encourage you to do that. We just want to acknowledge the funders as well. At the beginning, we started this with a small amount of seed funding, generously given to us by one of our colleagues' employers, the Southern Health and Social Care Trust and the Northern Ireland Social Care Council. And that's how we managed to do the first survey. Following that, the Public Health Agency, R&D Department in Northern Ireland has funded the remainder of the survey. So I'll just need to give them a mention. So, and of course, King's College London with Jill Manthorpe, we are indebted to them as well for the support for this social research policy unit. there. So thank you, Denise.